In previous years, I think we've heard a lot about single-agent therapies and how new agents are now going into clinical trials and being tested. Whereas this year, I think what I found particularly interesting was the combination therapies, because we know from the patients in the trials in relapsed CLL that single agents, although they're able to control the disease in CLL really well, they probably don't cure CLL. This year's ASH was really about trying to start combining different new agents, and there were lots of different combinations, and lots of different combinations are being trialed. In particular, antibody therapy with Venetoclax, the Ibrutinib backbone with Venetoclax, or antibody therapy such as obinutuzumab in particular. I think what was interesting to see was that maybe the addition of the antibodies is not going to make that much of a difference. That was at least my take-home message. So data from Jan Berger, he was looking at Ibrutinib, rituximab versus Ibrutinib therapy, and although the MRD rate was slightly higher in the rituximab-treated patients, actually there was no difference in progression-free survival and overall survival in patients receiving just Ibrutinib without rituximab. That might be different for other antibodies, and we still have to wait for these data to come out. But what I find interesting is that clearly the addition of the antibody has got a lot of extra complications for the patients, and also for the hospitals, because we need extra chair time. We need to give, it's an intravenous infusion, whereas going for combination regimens that are purely oral is much more convenient for patients. So what I found particularly interesting then was the UK Clarity study, because the Clarity study is looking at combining Ibrutinib with Venetoclax. This study had very impressive rates of minimal residual disease and inducing MRD negativity at 8 months in about 40% of patients using this combination. So I thought that was really for me the highlight of the meeting so far.